Hey, Appy.
Hi, puppy. I guess we are good for each other.
Yeah, what do you mean?
I mean, good study partners.
Can we discuss cystic neoplasms of pancreas?
All right, let's start.
Today, we shall be learning a very important topic of cystic pancreatic lesion. This is very important because in our day-to-day practice, we encounter this very frequently, as well as these lesions often find their way into multiple exams, including the MD-DNB final exam or competitive level exams. So, coming to the modalities that are radiologically available for diagnosing them, they are ultrasound, CCT, CEMR with MRCP. Coming to ultrasound, this predominantly helps us in lesion localization. However, the characterization of the lesion is quite poor on ultrasound. In CECT, it is multiphasic CECT. The protocol depends upon the institute and varies accordingly. It helps us in better characterization of the lesion when compared to ultrasound, and it is the best modality for staging the extent of the disease. Next, coming to CEMR with MRCP, this is the investigation of choice for the characterization of the lesion. Also, it helps us to tell a very important factor in cystic pancreatic lesions, that the MRCP helps us to identify ductal communication of the lesion. Let us now classify the cystic pancreatic lesions. This classification is based on the morphology of the lesion. So once you identify a cystic pancreatic lesion, you first need to rule out pseudocyst. Pseudocyst will have history of pancreatitis, history of trauma. Patient may also have chronic pancreatitis, need not always be acute. Once you rule out a pseudocyst, you have to go to cystic neoplasms of pancreas. They can be of two variants. They can be microcystic or they can be macrocystic. In macrocystic, it is usually a mucinous cystic neoplasm. In microcystic, we again divide them into two based on main pancreatic duct communication, which I already mentioned that MRCP is the investigation of choice to identify this. So if there is communication, it is a side branch IPMN. However, if there is no pancreatic duct communication, it is likely a serous cystic neoplasm. We can also divide the cystic neoplasms of pancreas based on location. These are the most common location they are found in. Not always will you get these neoplasms in these regions. First, as I said, we have to rule out a pseudocyst. Pseudocyst can occur almost anywhere in the pancreas. It usually has debris within. Next, we'll start from the head. In the head, the serous cystic neoplasm are the most commonly located. Next, in the uncinate process and in the head, IPMN, that is branch duct type or side duct type, are located. A mucinous cystic neoplasm is most frequently encountered in the body and the tail of pancreas. IPMN main duct type, same. Body and pancreas. Body and tail of pancreas. Let's start with pseudocyst. Now the discussion on pseudocyst is already well covered in our acute pancreatitis and chronic pancreatitis modules. You can go ahead and watch them in our channel. I shall just be brushing upon it. Now this is a typical example of a pseudocyst where the patient had history of chronic pancreatitis, where you can see in the CT that the main pancreatic duct is dilated. It is irregularly dilated. He has a pseudocyst, a thick-walled, well-defined cystic lesion in the head and uncinate process of pancreas, which is causing mass effect in the form of dilated biliary radicals. Okay. Now, let's dive into the cystic neoplasms of pancreas. Now, we shall be studying them under various headings, that is the name of the lesion, the age of presentation, the most common gender affected, the most common location, imaging features, special features, and finally, we shall see some images in order to fortify our knowledge. Let's start with serous cystic neoplasm. Now, this most commonly is known as a grandmother lesion, meaning it occurs after age of 60 years. It has a high female predilection. Now, what I want all my residents to remember is all cystic neoplasms have a high female predilection except IPMN. All of them cystic neoplasms, female predilection except IPMN. Now, most common location we already saw, it is the head of the pancreas. Coming to imaging features, there are two types of serous cystic neoplasms. They can be divided into microcystic as well as macrocystic. Microcystic and oligocystic. In microcystic, these are usually more than 6 cysts which are less than 2 centimeter in diameter. They have thin septations, and a very important feature is they have central calcification which gives a stellate scar appearance. We shall be seeing this image. However, I want all of you to imprint this in your mind that central stellate calcification, multiple cysts, it is a serous cystic neoplasm. More than 60 years, you are almost 100% certain it is a serous cystic neoplasm. In oligocystic variant, this is also known as the macrocystic variant, it is usually multilobulated. There is no communication with pancreatic duct and there are less than 6 cysts. Now, an important thing is we usually get confused between serous cystic neoplasm and branch duct variant of IPMN. Again, I have mentioned previously in the classification that if there is no communication with main pancreatic duct, it is serous. If there is communication, there is IPMN. It has some clinical implications as well. Suppose you do an ERCP guided FNAC and you aspirate the cyst fluid. Now, once you give the cyst fluid for histopathological analysis, what you will find is this has low amylase lipase level, as this is not communicating with the main pancreatic duct. Also, glycogen content within the fluid is high. Now, serous cystic neoplasms are usually benign. They do not cause any problem. Their treatment is just wait and watch. This is a no-touch lesion. As soon as you see this, you tell the surgeon, do not touch it. But there are some signs of malignancy that need to be ruled out. If serous cystic neoplasm is progressing to a serous cystic carcinoma, it will have an enhancing solid component that is in the form of a mural nodule. Okay? And if you find multiple serous cystic neoplasms, this is common in von Hippel-Lindau syndrome, VHL. Alright, let us see some images. This is a contrast enhanced CT of the patient where you can see a well-defined multiple cystic, that is polycystic or microcystic variant with central stellate calcification. Yes. Next, we shall see the MRI of this patient. We can see on T2 weighted imaging here that involving the head of the pancreas, there is multicystic lesion that are usually polycystic, that is multiple tiny cysts with central stellate scar that is represented by calcification. This is the venous phase of the contrast enhanced MRI. We can see that only the peripheral rim is mildly enhancing and few of the septae are enhancing. So this is likely a benign lesion, not a malignant one. Next, this is another case which we encountered where we can see a well-defined polycystic variant of serous cystic neoplasm. As you can see, all my examples classically involve the head of the pancreas that is usually seen in these type of neoplasms. We can see here clearly on the venous phase that the septae are showing enhancement. This is another zoomed image where we can see that the lesion is composed of multiple cysts that are tiny, and there is a central scar that is formed by calcification. This is a T2 weighted image. Alright, now let us learn the mucinous cystic neoplasm. This is often known as the mother lesion. It is often seen in females aged 50 years. Now you can see that this is again more predominant in female, but I want my residents to remember mucinous cystic neoplasm by a simple thing, that is, it starts with M It almost never occurs in M, that is male, and it is seen in mothers, again M. So mucinous cystic neoplasm is a mother lesion and almost never occurs in male. As I've mentioned before in the classification, this is very commonly encountered in the body and tail of the pancreas. Compared to its serous counterpart, this is usually a large lesion that is more than 2 centimeter. It is usually unilocular but can have less than 6 cysts. It has multiseptated and it has thick enhancing walls. Now, what I want you to know is mucinous cystic neoplasms are not benign like the serous counterparts. They are usually pre-malignant, with 1/3 of them having potential to transform into mucinous cystic carcinoma. So what predicts malignancy? The septae that show enhancement, mural nodules which are enhancing, internal hemorrhage, peripheral calcification, and papillary projections that enhance. These are the features that predict malignancy. The peripheral calcification is quite specific to mucinous cystic neoplasm. Especially this is helpful when there is a pseudocyst and mucinous cystic neoplasm and you have to differentiate both of them. Especially a unilocular mucinous cystic neoplasm, it's quite difficult to differentiate from pseudocyst. However, if you get a peripheral calcification, if the age matches, if the patient is a female, you first put mucinous cystic neoplasm in your differential diagnosis. The special features are it is pre-malignant, as I have already mentioned, and treatment is surgery. Let us see some images. This is contrast enhanced CT. This is the venous phase. We can see a large unilocular cystic lesion with multiple internal enhancing septae involving the body and the tail of the pancreas. We can see below that all the septae are enhancing. There is a tiny mural nodule here that is also enhancing. This is a classical mucinous cystic neoplasm. This you can see a unilocular variant of mucinous cystic neoplasm. Here there is peripheral calcification that fortified our diagnosis and helped us differentiate from a pseudocyst. This patient also had chronic pancreatitis. So this important calcification was quite important. Next, we can see on MRI, this is the T2 weighted image. We can see a mural nodule here. We can see that the lesion is involving the tail of the pancreas. It is showing thick peripheral rim enhancement on venous phase. Actually, I haven't included the mural nodule. That also was showing enhancement. So this is a mucinous cystic neoplasm. Coming next, this is a close differential to serous cystic neoplasm. It is the branch duct IPMN, intraductal papillary mucinous neoplasm. Now this usually occurs in 60 to 70-year-olds and is more common in male, as I have said before. It can involve the head and the uncinate process. The uncinate process involvement is quite classical. So you have to remember that this can usually be unilocular, but if you get a bunch of grape appearance, you are more confident in the diagnosis. Now, this is where MRCP plays an important role. If the lesion is communicating with the main pancreatic duct, then only you label it as an IPMN. Otherwise, it can never be an IPMN. And MRCP is the investigation of choice. In serous, we did UUS guided FNAC. There, we did not get amylase level. But here, since it is communicating with the main pancreatic duct, it will have high amylase level. Then CEA levels are also elevated and CA 72.7 is elevated if the lesion is malignant. Now, what I want you to understand is these are not benign lesions. They very frequently undergo malignant transformations, the IPMN. We shall study in detail what to look for on imaging if they undergo malignant transformation. However, I want you to keep in mind at this point of time that malignant transformation in branch duct IPMN is less frequent as is encountered in their main duct counterparts. So coming to images, this is a classical T2 weighted images where we can see that the uncinate process is involved by this multicystic lesion that is showing bunch of grape appearance. On MRCP, we can see that this is communicating with the accessory pancreatic duct. Now, this was actually a very interesting case that we encountered. The patient actually had pancreas divisum. We can see here that this is the main pancreatic duct, this is the accessory pancreatic duct, and these are small IPMNs that were communicating with the main pancreatic duct. The large one was communicating with the accessory pancreatic duct. This was quite an interesting case that our team handled. Now, let us study a little bit on main duct IPMN. This is very frequently encountered in people aged over 60 years. It has a male preponderance and involves the entire pancreas. The most common location is the body, but however, we see quite frequently that the head, body, and tail, all three are involved. Its imaging feature is quite classic that there is marked dilatation of the main pancreatic duct associated with internal mural nodules. There are also multiple debris or hemorrhagic contents also that you frequently encounter, and there is associated pancreatic parenchymal atrophy. I'm sure all of you are familiar with this diagram, that on an endoscopy we get a classic fish mouth appearance with mucin that is coming out of the tumor into the D2 duodenum. Now, I've told you before that this has a higher rate of malignant transformation than their branch duct counterparts. Let us see an image. We can see here that on this CT, the MPD is grossly dilated and there is parenchymal atrophy. Let us see the same on the MRI. This is another case. We can see here that on the MRCP, the entire main pancreatic duct is dilated. We can, on T2 weighted axial images, we can see that there is a solid nodule within the dilated pancreatic duct. Now, these are the T1 pre-contrast and post-contrast image. You can see that the solid nodule is showing enhancement. This is a classical main duct variant of IPMN. This is another example where the lesion was isolated only in the tail. We can see that the MPD is grossly dilated in the tail. This was a very interesting case. For the next lesion, we come on to SPEN. It stands for solid papillary epithelial neoplasm. It is usually encountered in daughter age group, meaning 20 to 40. So mother was mucinous, grandmother was serous, daughter is SPEN. It is again more frequently encountered in females, and it is involving both the head, tail, and well as the body of pancreas. Coming to its imaging features, it is usually a large lesion which is well encapsulated. It can purely be solid or it can be solid cystic. Now, what you have to remember here is cystic changes are common in the center and they can be associated with hemorrhages. Calcification is also found in 1/3 of the cases, and now you can see that this is quite non-specific that I have mentioned. What puts the specificity is there is peripheral enhancement on the arterial phase that comes on progressively filling the lesion in the venous phase. So this should ring a bell that it looks similar to hemangioma in the liver. The imaging characters are similar. It does not look actually like a hemangioma, but it is described that the peripheral rim enhances first, then slow filling of the solid components in the venous or the delayed phase. We'll see some images. Before that, again, this has low malignant transformation potential. Now, this is a classical example where I have shown the non-contrast. This is the arterial phase. This is the venous phase. In the non-contrast, we can see a well-defined mass that looks encapsulated involving the distal body and tail of pancreas. In the arterial phase, the peripheral rim is well appreciated. However, the internal solid components are not enhancing so much. In the venous phase, we can see that these internal solid components have shown even more enhancement when compared to the arterial and non-contrast phase. This is another image. This is the T2 weighted MRI, where you can see that the lesion is involving the head and the uncinate process. The age was 25. It is a well encapsulated lesion, as you can see by this T2 hypointense rim that I'm drawing over here. And on post contrast image, this is the arterial and this is the venous. In the arterial phase, it is showing peripheral thick rim enhancement, and in the venous, there is mild filling in. So, coming to the last in this sequence is the cystic neuroendocrine tumor. Now, this is common in 30 to 60 years and it has an equal preponderance between male and females. It commonly involves the body and the tail. Now, as all neuroendocrine tumors in the body, this is a hypervascular lesion that enhances avidly in the arterial phase, and its very specific feature is the lesion enhances more towards the periphery. That is extremely hypervascular. It does not wash out on the venous phase. Now, the clinical feature depends upon the histological subtype. Insulinoma, glucagonoma, VIPoma, all of them have different clinical features. I'm sure that all of you are already aware of. Now, this has a very high association with syndrome associated with MEN1, von Hippel-Lindau, tuberous sclerosis, and neurofibromatosis 1. Let us see an example. This was actually a 28-year-old woman. We can see here that there is a lesion in the non-contrast phase involving the head of the pancreas with central calcification. Here, in the arterial phase, we can see that the periphery of the lesion is enhancing brilliantly. In the venous phase, we can see that again the brilliant enhancement has not washed out. This is the MRI image of the same patient. We can see here a T2 weighted, this is the T2 weighted image. We can see a T2 heterogeneous lesion involving the head of the pancreas. This is the haste T2 weighted fat sac. Again, similar lesion. On the arterial and the venous phase, we can see that the lesion is brilliantly enhancing and there is no washout. So we are done with the diagnosis of the cystic pancreatic lesion, especially the characterization. Now I'm sure that most of you, if you encounter a cystic pancreatic lesion, you will figure out where to place it. If you are unable to pinpoint, giving a differential diagnosis will also do. Now next, what a radiologist needs to know is how to treat. Now, why is this important? I always tell my residents that your report should direct the treating gastroenterologist or the physician or the surgeon to where the patient must be treated, whether he must go in for surgery, whether chemotherapy, or whether follow-up. Now, this knowledge will come only if you know what the treatment is, what are the criteria by which you will define if the patient will go to follow-up, if the patient will go to surgery, or will stay on chemotherapy. Now, first thing that you need to know is which will clear cut go to the surgery. There are three neoplasms that will directly go to surgery. First is main duct IPMN. These have a very high malignant transformation potential. Then mucinous cystic neoplasm. Again, 1/3 of them transform into mucinous cystic carcinoma. Very, very dangerous. They usually have liver mets. Then another thing is branch duct IPMNs or other IPMNs that have high risk stigmata. Now, what is this high risk stigmata? There is a consensus known as Fukuoka consensus or the Tanaka criteria that is used for IPMNs, and they divide it into high risk stigmata and worrisome features. Now, these features must be included in your report as they guide the treating consultant to where the patient will go, whether he'll land up in surgery or follow up. Now, this is the Fukuoka criteria. Now, once you encounter an IPMN, you have to see whether the patient has high risk stigmata. High risk stigmata are three. One of them is obstructive jaundice, an enhancing mural nodule that is more than 5 mm, and the main pancreatic duct dilatation more than 10 mm. If one of these is present, then the patient directly goes for surgery. If they are not there on your initial scan, then you have to search for worrisome features. These features are just mellowed down high risk features, meaning mural nodule less than 5 mm, thickened cyst wall, main duct dilatation 5 to 9 mm, abrupt pancreatic duct narrowing with distal atrophy, cyst more than 3 cm or growth rate more than 5 mm per 2 years, elevated serum CA19-9, peripancreatic lymphadenopathy. Now, if these are present, then the patient goes for endoscopic evaluation, and based on the gastroenterology criteria that are based on main duct involvement, cytology, mural nodule, he will decide whether it will go for surgery or whether he'll go for follow-up. Now, if endoscopic evaluation, he does not get any abnormality, then the patient directly goes to interval follow-up based on the largest cyst size. Now, based on the cyst size, again, they are divided into when the patient will go for follow-up. Larger the cyst size, smaller the interval duration between each scan of follow-up. So that's it for today. I hope all of you have clearly understood neoplasms, especially cystic neoplasms of pancreas, and are able to characterize them properly when you encounter them in your day-to-day basis.
You made the topic quite simple. Brilliant.
You owe me a treat then.
I am getting late to reach home. Better luck next time.
Hey guys! If you like our simplified approach to difficult conceptual topics, please do comment, like, share, and subscribe to our channel.